Maybe I can. So it is really a very great opportunity for me to introduce these studies, and maybe we can have a discussion for the future. How can we enhance these studies? So just as the Prof. Button just introduced, I'm Zhe Yifang. You can just call me Zoe, and I'm from Shanghai Fudan Universities. So today, I think we are talking about the studies about how to measuring the integration between HIV, TB, malaria services and maternal and child health care services. And we use a case from the DRC. So I think I can briefly introduce about the background of our studies. So we have already witnessed that the development assistant has played a very pivotal role in enhancing the health outcomes in many recipient countries. But however, a phenomenon we cannot ignore is that the fragmentations sometimes persist in many African countries. This may be due to the challenges of them to mobilizing and coordinating this external aid and some conflicts between donor priorities and so on. So integrated health services delivery models maybe can give a solution to this kind of problems. We have already seen some guidelines be released. We can see since 2014, the WHO has already given the technical guidance note about strengthening the inclusion of reproductive, maternal, newborn, and child health in concept notes to Global Fund. And we already have African Union's policy brief also related to these topics. But the research evidence is still very limited. And also the existing data has showed that the integrated service coverage in sub-Saharan Africa is still very low. And also most published research only focus on single diseases, primarily HIV. So therefore, our study wants to measuring the integration between all of the three diseases and the maternal and the child health services to explain whether this integration has already occurred and to what extent the services integration has been. So we may have the findings to support the future development of integrated health services systems. So this is our study design. So first of all, I think we should define what is the service integration between HTM and the service and MCH service. So from our study, we may define it at the facility levels. We pay attention to we think the integration should be that facilities have the capacities and enough resources to provide HTM and MCH services simultaneously. So we included participants that is all health facilities providing antenatal care and child health care services in Democratic Republic of Congo. And this is now cross-sectional studies. So, and we use SPA service of the 2000 and the wave at the 2017 to the 18. And so overall, we have included 1,286 facilities, and they are at different level of facilities. So we defined, we categorized all the facilities into higher level and lower levels. Lower levels, we mean hospitals, hospital centers, clinics, and health centers. And the higher is referred to the tertiary, provincial, and general referral hospital, also referral health centers. And this is the indicators frameworks we have now designed and developed. We mainly referred to the four guidelines, I have mentioned before, and also the WHO service availability and the readiness assessment, and also WHO recommendations on the ANC for positive pregnancy experience. So maybe we can go through the indicators.
TB one.
Oh.
Okay. No problem. Please continue this.
Okay, so I just.
Let's start with TB. Start with TB.
Okay, we can start with TB. So actually, we define this indicator frameworks. All of the framework contained 4 or 5 dimensions, which is first of all the availabilities, and secondly the staff and the training one, and the diagnosis and medicines. So for TB, the availability is just ask if the facility can offer the MCH and TB services simultaneously. Both of the services can be offered. And then the staff and the training part, we pay attention to if we have providers that have abilities to provide ANC, child health, and TB services. So we specifically pay attention to HIV and the TB co-infection services. And for this part, we also included indicators about the guidelines for HIV and the TB co-infection, and guidelines for TB services, including case management, treatment, and follow-up. And for diagnosis part, we included observed system for routinely TB screening for HIV clients, and for testing TB patients for HIV infections. And also we ask if the providers has provide the diagnosis of TB at the services site. And for the medicine part, we included indicators that if the facility has the medicine stocks here just in the site. So we include medicines for TB treatment, and also if we have provide preventive treatment for TB, especially in HIV services areas. And the total framework of indicators is similar in all the 3 diseases. Like for HIV, but it is different. Maybe in HIV, we have another dimension named equipment. We pay attention to the privacy of the PMTCT areas. And I think we can have a specific look at all of these indicators when I show our primary outcomes here.
For malaria, anything specific to
mention? For malarias, and also for malarias, we also have some trainings about the child health. For example, we will ask if the facilities have the providers have already have ever received the training about malaria treatment and diagnosis in children specifically. So this is a whole picture of all the 3 diseases, the integration degree of all the 3 diseases. And MCH.
Sorry.
Yeah.
So before going to the results, can you comment on the methods part? Ask a couple of questions. So how many facilities are being included in this?
Oh, okay. It is 1,286.
They're all in
DRC, yeah.
They're all in one country.
That's in one country. That's use the data from DHS and SPA.
Yes. Yeah. Correct. Okay. Good. Then.
But this was why go in 2017 and 18.
Yeah.
Okay. Because to have 2 surveys. Around same period of time.
Yeah.
It's not that easy.
Yeah. So the study actually focused in this period.
Yeah. Only DRC.
Yes. DRC in 2017-18. Okay. So the next slide. So why did you want to look at PMTCT for malaria? Or is it IPTP you mean?
Maybe.
Okay, that's right. Okay, maybe IPTP.
Yeah.
Okay,
sorry.
that's fine.
Sorry for that.
No, that's fine. I just was curious a little bit. Yeah. So it's just, so what you looked at well is ANC and PMTCT, IPTP.
Yes. And it is at least it is ANC and malaria related services. Sorry
okay,
about
no
that.
No problem.
Maybe while you're still here.
Yeah.
while you're still here, maybe I can quickly ask a question. So am I correct in my understanding that these indicators were derived from these data sources, which you've highlighted at the top left corner? Is that correct?
The indicators from those frameworks.
Exactly. Did you derive the 3 sets of indicators from the framework, from those 4 documents that you have listed at the top? Or you created your own list of indicators?
Oh, yeah, I think we primarily referred to the services availability and the readiness assessment.
Sarah.
Yeah, Sarah.
Sarah. Okay.
Yeah. And we also referred to other guidelines to pick out the important indicators.
Okay, thanks. Please continue so that we can.
Okay. So that we have the whole picture of this integration degrees in 3 diseases areas. So we can just see that the green colors refers to the better, higher level of integrations, and the red one refers to lower level of integration. So from diseases to diseases, we can see that malaria maybe has a higher level of integrations. Some indicators maybe has already achieved the 100%, but the TB, talking about the TB, it is really relatively low, and the HIV is at the middle level. And pay attention to the sub-index, I mean the different dimensions, maybe the staff and the training and also the medicine part has a relatively lower scores. Yeah, and this is a whole situation in 3 diseases, and I'll go through the diseases by diseases. So for the HIV, first of all, we have the availabilities asking. So we actually have 2 kind of data collected ways. The first one is reported by the health workers. It is just during the interview ask the workers, does the facilities offer both services? And another way is observed by the viewers. So the interviews may all observe if the HCT is or actually done for all ANC clients. And we can see that when it is reported, the MCH and the PMTCT are the percentage of it is about over 50%. But if when it is observed by the interviewers, the percentage may be half down, only 25%. And the second indicators, it is like be asked if the providers has provide HIV counseling and testing as a part of ANC. Yeah, and the situation is that the reported data is usually high, but the observed one is sometimes lower. And then it is the staff and the training part. We can see that one of the relatively low is talking about if the ANC PMTCT providers has received PMTCT related trainings. We can see we have 50% of facilities have at least one providers providing ANC and PMTCT services, but only 22% of facilities have at least one providers have already received refreshing PMTCT trainings. We use the indicators that refer to the PMTCT trainings happens in the latest 24 months. And then we should pay attention to another situation is that when we ask, it is also does the facility has at least one providers received pediatric. It is also child related HIV and treatment and case management trainings. The percentage is also quite lower. And the percentage of equipment and diagnosis is about 50%, and the medicines is like 30%. Okay. And
it's very interesting to have this reported and observed the discrepancy here in the cell. I don't know. It might be interesting to look at by fields of facilities. So low level facility, that's a tertiary, that's a when they try, of course, people, if they have that set up, they will offer the service for both ANC and HIV related services. So they may just report that. But in that data, when you do the SARA assessment, probably service is not there. Especially for primarily the low level. They may not have client come for that specific service, but that may be different in the high level. When they have tertiary, probably they have more clients, and even during the day, you may be able to observe. So it's interesting to look at by different levels of facility to see how they're different.
Yeah, I was also wondering. I think probably your explanation makes sense. I was also kind of wondering if people were differentially interpreting the questions. For example, the first question is like, please tell me if provider in this facility provides HIV counseling and testing. The second one actually talks about whether this is routinely done. And people probably could say that, oh yeah, they provide, but it's not routine enough. And then the people could be more conservative in response to the second one. So that could also be probably partly the thing, people say that, yeah, we do HIV testing in this, but then when you ask actually that, do you routinely do, and the people say, oh, no, not always, sometimes we have stockouts, and then we may not do it. So maybe it's an interesting question that might require a little bit of exploring, digging, a little bit of deep dive to understand what exactly explains this huge difference between the two.
And also, there's a matter of understanding about routine. What do we do? It's open every 3 days. Just during that day, that's when they did the assessment. That day was not offering. So that's also routine. Does not mean that's every day, all the hours.
I think routine maybe mean all the ANC clients, when they come, they should do this.
So they need to go back to the original report of how they define routine. I don't know.
I think, okay. I think it's maybe also decided by the frequency of the ANC frequencies.
Yeah.
So, okay, when they provide ANC, they'll provide the HIV testing counseling. Okay. So that can make sense also.
Yeah, okay, so I go to the next slide.
Yeah.
Just one comment also on this one, particularly on I think it's maybe it was on malaria. There was one question that I had. Probably let's continue.
Okay. And this is a situation about TB. And when we are asking, does it actually, so first of all, the indicators related to the TB in the SPA is sometimes very less than the other malaria and HIVs actually. So, and when we go through about the services availabilities, the reported rate is relatively high. However, when we come to the staff and trainings, it become really low. But this may be because we included the data like providers providing ANC and the HIV, TB co-infection services. This is why the score is so different between each other. So, and also when we are asking if the facility has at least one providers received TB, HIV co-infection related trainings, the percentage is become really low. And also I think it is interesting that if we ask at least one providers providing child healthcare services and HIV, TB co-infection services, the percentage is a little bit higher than the ANC and HIV, TB co-infection services. And then we talking when we're talking about diagnosis, first of all, the observed system for routinely TB screening in HIV positive clients is only 15%. And also the providers use a TB rapid diagnosis test to diagnose TB is only lower than the 1%. However, the stock of the medicine is maybe a little bit higher. About 40% of facilities have medicine stock for TB treatment. Yeah, and that is the situation of the TB.
Do we do
My
this,
hand is up.
Yeah, do we do TB diagnosis for pediatric? I mean, that's for children at MCH services. I don't know. That's or we have like TB specific clinic.
So I'll answer your question, Jinko, as part of my comment, if that's okay.
Okay, please. Sorry.
Yeah. So Zoe is what you say you prefer to be called, right?
Yes.
Thanks for the presentation so far. I think this is a lot of information. I'll just share a few reflections on the TB slide. In my head, as we're presenting, I was wondering, how did you end up with DRC of all countries to be the country of choice here? But of course, you've already gone there. The data is available and you're using it, so that's okay. I just say that because you see the 0.89 DRC is probably one of the lowest for this in the world. So you are just looking at the complete other spectrum of this. So some quick questions, not questions, comments. Normally, TB and ANC, the connection is not as strong as you probably see in malaria. So you already said, the questions are not so many, and that's true. It's just the nature of the disease and some of the services. Pregnant women, while they're important, no TB program is going to lose sleep over pregnant women. It's just like, almost any other woman. Children are an issue, but how and where they provide the services are a bit different, which links to Jinko's comment. TB testing in children is really a specialized task. And one, it's going to be hard for you to find a single person at ANC who just does this, because it's mostly nasogastric aspirates that they use. You have to be really trained in that skill. Now we've started stool testing in some places. It's just started, it's catching up and things like that. So it's not going to be shocking to see that it's not as widespread, especially for malaria. But of course, the data is what it is. But I'm just saying this because there are these nuanced contexts that you may need to provide while you are referring to this information. In addition to that, some of what we're even seeing here as under the TB section should ideally be under malaria and under HIV. For instance, observed system for TB screening HIV clients. Observed system, providers. There's something about, TPT in HIV service area. So I'm not sure how the guidance put this, because there are two layers, and probably that explains why one of the question has that score, where it's looking at TB HIV co-infection, because there's first the integration of TB and HIV, and then you are now also trying to integrate, not you, but also the question is trying to now look at TB, HIV, and ANC. That's quite a lot, and this is 2017, 2018. The whole one-stop shop concept had not picked up generally, where TB, HIV services are provided by one person at the same place, at the same site. The person can cancel, can do the test, things like that. It's only has gained traction recently. So that's just one other thing. But generally, of course, this is what the data says. But I I would imagine, I don't know if it's the SARA form that put it on the TB, that maybe some of these things are better co-located to HIV, but also generally the context of the nature of TB. Because if I look at TB, MCH and TB services offered 92.17%. And then diagnosis offered. I don't know from the document what falls under these services. I know for sure that nutritional services, vaccine services, because TB, you have the BCG vaccine. You could have prevention, so provision of TB preventive treatment to children, contacts. That's also another important one. That for me is more important and should be under medicine than provision of TPT, preventive treatment for TB in HIV. That falls more under HIV, and that's more priority. Of course, general screening for TB happens all over the facility, not just the ANC. So anyone who comes in with cough or symptoms suggestive, but of course, the ANC platform is another place that can be leveraged to see whether pregnant women or their children have this situation. So I just wanted to, kind of provide this additional context, and of course, happy to share more information if needed. Thanks.
Well, thank you so much for the recommendations, because for me, sounds so at the beginning, it is really difficult for me to decide what kind of indicators I should include it in the TB part, because just as you mentioned, it seems like at the different levels, the TB. So you mentioned before, it should be linked to the HIV first, and then maybe be linked into the maternal and child health care. Do you mean, am I understand correctly?
Yeah, so integration for TB starts with HIV, because among HIV patients, TB is the largest or the main cause of death there, right? And so there has been a lot of work on integration of TB and HIV services, both by the global partners, but also at country level and down to facility level, where we see this. ANC is not the first thing you will try to integrate with TB. It's probably to even look at other lung diseases first before you start looking at ANC, just because of the nature of the services that are provided. But it is an opportunity. I'm just saying the way that question is framed is looking at ANC and TB HIV, but TB and HIV first have to be better integrated before you start checking the link with ANC. That's all I'm saying.
Yeah.
It's a very, very good point. The TB got its own uniqueness in this context.
And also, I think for the training question, it would be also good to have a separate question on whether at least one provider had received training for TB, on TB diagnosis and treatment, probably because you have one on HIV, TB HIV co-infection, which is fine. It would also be good to have one separate for, just check actually how many were trained. I can see that about 22% of the facilities were providing TB. I believe probably at least 22% of the facilities should have a person that is trained in TB. I don't think they would be able to provide TB care without having any training. And this also reminds me of actually the question that I forgot on the HIV part, which is actually cross-cutting probably over all three. In terms of the training, so was it about the in-service training, kind of, or training at any point, or at a given, like over the last year? How actually was the training thing actually assessed?
Yeah, it's more
or ever trained?
Yeah, more like in the latest 24 months. So it's like a
over the last 24
months.
Okay, I see. Okay. Whether they have really received any refresher training over the last 24 months. Yeah, would be good to clarify that, so that at least people know that. People say, I've been trained there, in my basic training, as part of my basic education, I know about it. So yeah, it would be
actually I asked the same question the other day.
Excellent. Yeah.
move to malaria.
Okay, we move to malaria. And just as mentioned before, the malaria situation is more integrated. And like the facility percentage of facilities offering MCH and malaria services is achieved the 100%. And also in the diagnose part, the facilities provide malaria diagnosis is also already achieved 100%. And this including blood tests with microscopy and MRDTs. But also the lower percentage, the lower score is occurred in the staff and the training part, where we are asking if the providers are trained in the latest 24 months. The percentage will be relatively lower, like 44%. Yeah. And also we have questions that facilities have at least one providers who received trial-related malaria diagnosis case management. And the percentage is about 49%. Yeah, and also we included the diagnosis indicator related to the malaria rapid diagnosis test used in the service site, and the percentage about it is 80%. And also we included medicine and commodity store in the facilities, and the SP facility available in the facility is like 77%, and the ITM mosquito bed net is the score is like 55%. Yeah.
Great. Yeah. Yeah, I think I'm not surprised because many primary healthcare facilities, in principle, 100% of all facilities are expected to provide malaria services, which is not the case for HIV and TB because they require a lot of training and more diagnostic capacity. I know that, as Namdi said, is probably more rapid, WHO recommended rapid diagnostic test is expanding. Probably you might see more primary health care facilities really reporting, but this is encouraging to see. Two comments. One is with regard to the site providing I think there is service in NC. Where is that comment? Provide RPT as part of NC, that's fine. Provide malaria RPT as part of NC services. So that is good. Maybe they are providing RPT services mainly because probably they suspected the pregnant woman of being probably symptomatic for malaria. Otherwise, it's not a recommendation to provide blanket RTT service for every NC mother. There is at the moment discussion as to whether we should use that as part of kind of malaria surveillance, like every pregnant woman just on the first ANC, just getting RTT to estimate the burden of malaria. But as part of service provision, it's not recommended. It's only if the mother is symptomatic that it would be recommended. So if, for example, some of the sites are not providing RDT as part of NC service, that's not an issue at the moment. Unless what you mean actually is that whether the NC services actually have a malaria diagnosis capacity, which is different from this, which means, if the suspect of a mother, do they have a possibility to diagnose, provide rapid diagnostic testing to identify whether the mother has malaria or not? That is fine. But it's not like, the HIV testing where every pregnant mother has to be tested for HIV.
Screened.
Yeah, but there is no requirement for malaria screening.
Yeah. Do we need to do some kind of testing before IPTP?
No.
Okay.
Because there have been several studies that show that there is no additional benefit of testing before IPTP unless the mother is symptomatic.
Okay.
So because of that, the use of RDT for screening is not recommended. So that 61% would be because of the guidance itself, and not probably because of lack of services. So it would be good to qualify that and then clarify that it's not actually a guideline that for every pregnant woman to be screened for malaria by RDT. But you could say that probably the fact that 61% of them have provided some RDT services would mean that probably they have the capacity if the mother becomes symptomatic. So we have to just clarify that. I think the training question, I've already commented on that one. Otherwise, I think most of these questions probably are fairly relevant and very good ones. One question that you have included on children is very good, and it's good actually that you pointed out that particularly the capacity and the training readiness to identify malaria in children has not been, the health workers have not been well prepared. So that's very important, given that in high burden settings, really malaria is really a problem of children and not adults. I would actually have also liked to really see if there was any services provided for severe malaria and also training on severe malaria, because the severe malaria treatment doesn't mean that the primary health care facility should actually provide the treatment on site, but there has to be a mechanism if they identify a severe malaria to immediately provide a referral treatment, which is rectal artesunate, and then quickly identify and then refer them to the higher facilities. So that's a requirement for all the health facilities. So it would be very important, because that's a big challenge in malaria, that people do not quickly identify severe malaria and then give that pre-referral treatment and then refer them to the senior health facility for admission and for severe malaria treatment. And that could actually, delay.
Don't worry, I'll share this recording, and they don't need to take notes.
The chance of survival, and then death could happen. So it's usually delayed treatment for severe malaria that usually leads to death among children. So it would be interesting actually to look in DRC. I hope it won't take too much time really to quickly probably scan through those documents and then see if you can include that on severe malaria. Apart from that, really, I don't have much question. I think you have done a wonderful job. Thank you.
Thank you, Jose. So I'll just go through to
Namdi has a hand up.
Yeah.
Namdi.
Yeah, I don't know how close you are to the end of the presentation. I wanted to give a comment, but
You still have time.
If it's going to disrupt you, then maybe you should go ahead.
Yeah, no.
You still have a few slides.
Yeah, we still have 6 slides. 6
6 slides, okay. Maybe you can quickly go back to the slide where you showed the results for the 3 diseases together. Okay. Quickly. I've already made some suggestions around the diagnosis. It's also important to note that not every facility is supposed to provide rapid diagnostic tests, right? When we say rapid diagnostic test, it's not like RDT for malaria that are small, it's the gene expert machine. So when couching those recommendations, I had mentioned MCH and vaccine, BCG. I mentioned the one around TPT, but for contacts for children and for testing. I was wondering, just looking at the one, again, still on staff training, if I look at the HIV one, it says have at least one ANC PMTCT provider receive PMTCT training. So it's taking PMTCT, which is just a component of HIV. It's not even talking about HIV training. But then when you go for, and when you, the one for malaria is obviously an error where it says PMTCT, but for TB, it's not only talking about TB, because the ideal thing would have been ANC and TB. It's also talking about the entire HIV, which is kind of a paradox here, right? So I wonder how, if there's other information, additional information and document that can help frame it a bit differently to look at either TB and ANC And then if it's talking about TB HIV, just focus on TB HIV because on its own, that's already integration. And then, you know, before we start building on ANC and HIV TB co-infection. All right, that's all. Please, you can move to the other slide. I don't want to delay you. Thank you.
Yeah, I think the main results already shown. Let's let's go through that model graph, presenting different way.
The following will be really quick because we also tested the difference between different level of facilities, the difference of the integration levels. So in the HIV related situations, the integration in lower level facilities are significantly lower and in every dimension and every indicators. And also this situation in TB is the same. The lower level of facilities has a lower level of integrations. And in the malarias, we most of the integration levels in different level of facilities, usually the difference is not significant. And only we have three indicators that is has significantly different. It is about the sites that have at least trained providers, and also the sites that have the training manuals, posters, training materials, and also and at least one providers received training related to the trialed malaria controls. And I have also tested the difference between the urban and the rural areas. So I only show the picture of the indicators that has shown significant difference. So we can see that in HIVs that there are 5 indicators that has showed difference in rural and urban areas, and usually the rural areas has a lower integrations, but in the TB and malaria areas, sometimes the rural area has a higher level of integrations. And this is this is another finding.
Sure.
And this is
HIV is so specialized. You know, that's when you go down to primary health care, that level, they do not have many people. The one person need to do everything. Hopefully.
Yes, and this is all the main results we have. And the next slide is about the additional final analysis. So maybe we have discussion about the outcomes, or we just go through the.
Probably we can quickly just go through this. That's next step. That's what you think.
So as we already have the primary outcomes of the overlying of the overall situation of the integrations. So we plan to maybe we can do more further analysis. For example, first of all, we may explore the logical relationships between the elements of providing the integrated health services, like trainings, staffs, and medicines, and how it will influence the integrated service delivery. And we can identify some key factors. And also, I just show the integration between HIV, TB, and malaria with the maternal and the child health care. So I haven't do the analysis about integration between the 3 diseases. And the third one will be the impact of the services integration. Maybe we can see how the integration will influence the population's health and health services utilizations further. And the fourth one is maybe so actually I am really interested about the implementation science, about how to implement such integrated services in specific countries and specific contexts. And the last one will be maybe more countries data can be included in. And that's all for the presentations I have.
This the data used is because we rely on the data already collected from DHS or SPA or the SARA. So data always a little bit outdated. And especially when I look at this, I'm very curious about this whole COVID impact this, but unfortunately we do not have much data to tell the story yet. So probably the one country is Senegal. They're doing like routinely that's DHS and the SPA. That's probably that country can can be used, the data can be analyzed to see this the trend of time. That's to see that. And the other thing that she mentioned about qualitative interviews, I think that's probably that the big survey data may not become available, but some qualitative interviews can be done to collect information on what people are actually practicing. And if we can probably select a few countries, of course, ideally, if that can be linked with the data already available from surveys, and then we say, okay, this country we can select a few like facilities and to have remote interview with a semi-structured interview guideline questions. That will be interesting to look at this.
Maybe I just make, because I have to drop out at 4 exactly. I have situation at 10. Zoe, great work so far. I have just dropped in the chat the link to the DRC DHS reports 2024, 2020, 2023, 2024. And so I think more recent information may be helpful. I've not looked at the reports, but it's DHS, right? So I think it'll be helpful. The other thing is number 2 here. You say integration between HIV, TB, malaria. If you want to look at that, then you may need to, it may require going beyond just facility level, because integration will now go into some policy, community activities, use of community health workers. The truth is, yes, the Global Fund is those 3 diseases, but the natural fit for integration is not really malaria and TB services. It's not your natural fit. Yes, if you're doing community campaigns, it's easier to even link diabetes and TB than formal. So we need to manage our expectations. If we want to look at integration of all 3 diseases, we go, maybe lab systems and look at what integration is happening, policy level, community level. That's where you likely see it. You may not see it at health facility. Of course, if you're in a primary healthcare center where one person provides all the services, I don't know if you call that one integration, but it's just because that's the only person there, right? So that's the other comment I have. I would have to drop off, unfortunately.
Before you go, that's because this as part of her PhD project, she will write it up. If the write-up that potentially publishable, will you be interested in being part of the co-authorship?
Sounds interesting. No problem. As far as we can contribute meaningfully, yes.
Yeah.
It depends on how much we'll be able to contribute.
Yeah, that's of course. She will write most of the first draft or something, and then you comment on the things. I think that today's a lot of comments already very useful. This normally before you go.
Yeah, thank you. I'm also leaving,
for me, yes.
Okay.
Now maybe you just comment and then I have one more comment.
Okay, please.
Are you done?
No, I'm done with my comments.
Okay, thanks. Yeah, but I think these are really great questions. But the way I agree with Namdi, probably looking at integration TB, HIV, malaria would be very difficult. TB, HIV is fine, but malaria is totally different. So probably the integration with maternal and child health platform, that's perfect one. For all 3, it works. It's wonderful. So apart from that, I think these questions are really great, but the impact part is going to be challenging. So be careful actually how you will be actually assessing this, because the impact at the population level could be a factor of many things beyond just the integration of the services. And if you would like to look at what kind of impact, probably it might be good to carefully select what exactly in terms of impact we'd like to see. Otherwise, probably you can carefully look at it and then probably don't rely too much on that. But the rest, I think, for me are very good. One thing probably I suggest you could probably consider is try to also look at the national average of the coverage of those indicators. Like, you have looked at the proportion of health facilities, like providing, for example, HIV vaccine services, but also the coverage of those services from the national report. You can look and then probably you can compare it with other 3 countries within the region. That information you can easily get from partner data. The advantage of that is probably to reduce some of the concerns that, for example, Namdi earlier raised, saying that DRC is not a good choice, for example, to look at the RDTs, right? Where does the national program stand vis-a-vis other countries within the region? So for a few of the countries, you can already look at where DRC stands vis-a-vis other countries. And then within DRC, you can actually look at the proportion of services. So that would really help you to put your argument in context. Just to add that point.
Very good suggestion. Very good suggestion. We can maximize the use of that.
Nice to meet you.
Okay, let you go.
I'm running to another.
Namdi, thank you
Great.
so much.
Thank
Let you
you.
go.
Thank you very much.
Okay.
All the best, Zoe. Bye.
Bye.
Yeah, bye. Thank you.
I have all this recorded. I'm
Okay.
still recording, and so I can share the recording with Professor Huang also. That's
Oh,
about this,
okay.
because I will share with Wang Limu, the other person who cannot join us.
Mhm.
I will share link. Probably I will save somewhere in the YouTube, and I hope you have access to YouTube.
Wow.
Yeah, because otherwise I have no way, because it become too big.
Okay, okay.
And also I can share with you now the transcripts,
Mhm.
basically what
Wow.
people said. Okay.
Right.
Stop recording. I did not.
这个你可以在网上仔细找一下去。
好的，
有一个 DHS
就是
program，
在那个 Teams 的，
不在 Teams，你不要做 Teams，这个 DHS
哦，直
program
接在 YouTube 上是吧？
不是在 YouTube，是 DHS program。
哦，这个
DRC，你去看它的这个 key
对，我知道这份报告我其实也有。
也有啊。
对对对。
一个事情，大家都默默地处理。
你正好消化一下。